Morning, morning everyone. Good afternoon to Rahul. Different side of the world to us in the UK. Welcome back, and we might have some new people joining us today. We've had a couple of new people join the group. So hi David, good morning. All good, all good. Yeah, had a good weekend teaching this weekend. We're doing part of our exercise therapist course, and it was the coaching and planning weekend. So that was good. Part of the movement therapy diploma. So if you're in the UK, fancy learning with me about all things therapy, then have a look at mte.academy or just search me up on Google. There's plenty of stuff about me on the internet. All good, I hope. So let's get going. I'm going to do a bit of a recap from last week for the nerves, and then move on to the blood supply. Going to link up some of the hip with the knee to start the next session, really. But when we start to move up into the hip area. And it kind of makes sense with where the vessels come from, and hopefully found last week's episode on the is mainly the nerves useful. Like I said, we'll have a bit of a recap today, so if it sparks any questions from last week, then feel free to ask if you're joining in live. Right, let's go to this. So this is where we started last week. We were looking at the compartments of the thigh. So and it's a good place to start again, I think, with the blood supply too. Morning, Tris. Good to see you in this morning. So if we start back here, so we were looking at this. Just grab my arrow there. So we've got, if you remember when we were looking at the connective tissue, we were talking about the fascia lata around the thigh, and then the thickening of the fascia lata around the lateral aspect, which is the IT band. And if you want to have a look at that in a bit more detail, then we did a session on that. But the connective tissue is then joined via these septums, wrapping around and creating segments within the thigh, which compartmentalize muscles and somewhat compartmentalize the nerves and the blood supply too. Although, as we saw, there is a little bit of a crossover. So these are really useful for dividing out these sections. So we had a look at then the muscles in the different compartments. Sartorius, that's it, vastus medialis, intermedius, vastus intermedius, vastus lateralis, rectus femoris. So they're all in this anterior compartment. In the posterior compartment, we've got the hamstring group. So semimembranosus, semitendinosus, biceps femoris. And then within that group as well, we've got the sciatic nerve. And then the medial compartment, in the anterior compartment as well, we've got the femoral artery, vein, and the nerve as well. The great saphenous runs just outside of those compartments because it's very superficial. So it's around the thigh area. It's one of the ones that we use to draw blood. So because of the superficial nature of that vein. And then the medial compartment, we've got the adductor magnus, adductor longus, adductor brevis, and then G is the gracilis. And we've got the deep femoral artery and vein. So it splits. So if we focus just on the artery and vein, it splits. And so we have, and we'll have a look at that today. So we've got a vein which is called profundus, which is means deep. Anything with profundus is like from the word profound, which is like obviously deep thinking. If someone is a deep thinker, they're profound. So profundus means deep, and we have profundus tendons within the hand and wrist. So we had superficialis and profundus in the flexors. So again, if you go back to the hand, then those are mentioned in there as well. Good morning, Natalie. Hi, Caroline. Usual crew in this morning. yeah, some of the names will give rise to where they what they're called, which is quite useful. So stuff to do with the femoral is obviously to do with the femur. So a lot of the names of the muscles and the compartments and the vessels, the nerves are all related to the bony structures. That's why we do those first. So very quick whistle stop tour through the nerves. And again, if you have any questions from last week, then please fire away. So we have the different nerves affecting the knee, and we were looking at because sometimes I think we get a bit confused with what's what. And well, I certainly did when I started learning. So we had motor branches supplying the muscles, sensory branches, sensation from the skin, and those are cutaneous nerves, and then articular branches, which is sensation from the joints. So the capsule, ligaments, synovial membrane around that kind of region. So we've got different names of different nerves depending on what they do. And then we had a look at those. So we had a look at the femoral nerve initially, and the different branches. I'm skimming through this because we did it last week. So motor branches, sensory branches, and the femoral nerve was split into two divisions. So we had an anterior and posterior division, and each division supplied different muscles. So we've got pectineus and sartorius with the anterior, so the motor supply. But then the sensory supply for this was the medial cutaneous nerve, and we were looking at the supply of the skin around the thigh, which was really useful if you have a specific compression of a nerve around that area, and then the intermediate cutaneous nerve as well. And then posteriorly, or the posterior division, the motor branch supplied these four muscles mainly, and this really small one, articularis genu. And then the sensory branch was the saphenous nerve, and there was an articular branch as well, which was an offshoot of those nerves for the hip and the knee. Okay, so we had quite a lot going on that posterior division. So 4 motor innervations, 1 sensory branch, and then 2 go into the 2 joints, the hip and the knee. So you can see where it all splits. And then we looked at this, which was a nice kind of breakdown of all of that from the book Instant Anatomy. Really, really good book. And it just lays out, especially for the blood vessels and the nerves, a really nice structure so you can see where everything is. Although, much like the tube map, as I was saying last week, this isn't actually how it looks. It's not obviously all nicely laid out like this. It's laid out like this so we can understand it better. But in the real body, it's a bit all over the place and overlapping. So, but yeah, this is a nice way to understand it. And then we have these arteries. We'll have a look at these arteries when we get to the hip. But this is where the division split of the femoral nerve was. It was around the what we call the lateral circumflex artery, part of the arteries in the hip joint that supply the hip joint. And then we've got the anterior division, posterior division, and then this posterior division ended up being the saphenous nerve, which was a sensory nerve down towards the leg and into the foot. Okay, so you can see here it's all the medial side of the leg. So because we're focusing, we went over that when we looked at the ankle and the foot and the supply, but this is where it comes from. Okay, so now you've got that kind of link joining the two. And yep, so that was supplying the anterior compartment, and then this was the sensory distribution for the skin. Okay, so the cutaneous nerves. So this whole red zone at the top, this is supplied by the femoral nerve. So that was your medial and intermediate cutaneous nerves, and then the saphenous nerve was down here. Okay, so this is the blue zone here, but it's an offshoot of the femoral nerve. So it's but it's just called a different name as we get lower down. And then the obturator, more inner thigh, this one. So this is to do with your adductors. And with the pathway was slightly different. So the femoral nerve, we'll have a look at that in a second because we're going to look at the what's called the femoral triangle. And so the femoral nerve goes over the top of the pubic rami, which is the branch of the pubis. And the obturator goes through this hole, which is the obturator foramen. So the whole around that area is called a foramen. And yeah, and again, see how the names are all kind of linked. So we've got obturator foramen, obturator nerve, and then we had a couple of branches of this nerve as well. So it splits off into different directions, and these were the branches. So 4 motor, 1 sensory, 1 articular for this anterior branch. And again, the sensory is the obturator cutaneous nerve, so the sensation for the inner thigh. So if there's a problem with the inner thigh skin sensation, then it is likely to come up from this nerve, although there is overlap. Okay, there is overlap in the cutaneous fields. So, but you'll have a good idea. It's either medial part of the femoral or the obturator cutaneous. It's going to be one of those two likely. Okay, so posterior, 2 motor, 1 articular branch. So 2 going to the muscles, 1 going to the joints. These were the muscles that it supplies. We've been looking at the adductor magnus. The obturator externus is part of the hip. So we'll have a look at that when we get to the hip, as is the pectineus. We've mentioned it a couple of times, but it's more to do with the hip. So we'll look at that in a bit more detail when we get there. But we have looked at these adductor brevis, longus, and gracilis, and they're all part of that. Apart from the obturator externus, all part of that adduction of the hip. Okay, so they and that's what obturator means. It means to close. Yeah, so closing the legs is adduction, adduction, and that's what those muscles do. And this is the nerve that does it. Okay. One of the interesting things about the adductor magnus, again, we've mentioned this a couple of times. It has 2 nerve supplies, one from the obturator and one from the sciatic, because it does slightly different things depending on the orientation of the fibers, but it's all categorized as one big muscle. So we have vertical fibers of the adductor magnus, which act a bit like a hamstring, and then we have oblique fibers of the adductor magnus, which act a bit more like an adductor. Okay, so that's why. And again, we looked at that when we covered the muscle. And then this was the schematic, again, nice, simply laid out. So you've got the different divisions, and then all the muscles and the areas of skin that these, or the articular branches as well. So the joints that it supplies, and this is in the medial compartment. Okay, so that inside part. So it groups things up quite nicely to learn them when you're studying anatomy, which is quite useful. And then this was the sensory distribution on the skin for that cutaneous nerve. And if you remember, if we go back, we've talked about dermatomes before, and we'll do that a lot more when we get to the lower back. So when we have a look at the origin of the nerves in the nerve roots, we'll have a look at things called dermatomes and myotomes. So when you have a problem, so up here in the lumbar spine, there's 2, it's 1 exit, 1 entry from the spinal cord. So we have the motor nerves coming out, and then the sensory nerves going in. And if there's a problem with the where the sensory nerves come in, you may be getting sensation like normal from the skin and from the joints, but as that information is traveling up into that part of the spinal cord where the message is relayed then up to the brain, if there's a problem there, some kind of compression as the information is trying to get in, you won't receive that information. And because the sensation is let's just get rid is let's say it's a problem at L2, there will be sensory areas around the hip and the thigh where well, let's have a look. So was a good one. So like the cutaneous branches on the medial aspect of the thigh will come up here, and then they will go through, they'll be shared a little bit, but it will mainly go through one nerve root. And if that nerve root's been affected in whatever way, some kind of compression, then it will knock out quite a wide area of skin. Okay, so because there may be several regions where that nerve root supplies, but if it's just here that's affected, so there's some kind of compression around by where gracilis is on the inner thigh, then it will only affect a small patch of skin rather than a whole area. And that's the difference between cutaneous fields, so what a small skin patch, or a dermatome, which may be a bigger area depending on what that nerve root, what information that nerve root's receiving. Okay, so that's because often they can get confused. You get weird sensation somewhere, and say for example carpal tunnel. So carpal tunnel could be a nerve root issue, but it can all the median nerve can also get entrapped anywhere along the pathway of that nerve. So if you examine the neck and the neck is fine, and you think, well, I don't know why you're getting your symptoms, you need to have a look at the other areas where the nerve may become compressed. So because that may be a localized compression causing those symptoms. And I chose carpal tunnel because the classic one is inflammation around the retinaculum around the wrist, which then compresses the nerve before it gets to the hand. So there's nothing wrong with your neck. The problem is in the wrist. Yeah, and that can be anywhere in the body as well. That can occur. So we need to. Sometimes it's not obvious though. Yeah, so you test it and you're not really sure. So then you need to send them for further investigation. It's sometimes it's just not black and white all the time. It's not like bang on obvious. There's lots of overlap with dermatomes as well as the cutaneous fields. So it can be a confusing picture, and sometimes we don't get to the bottom of things, but because we just don't know. But there we are. At least we can do a thorough examination and have a better understanding of what may be going on. And then the last nerve we looked at was the sciatic. So this is your main nerve coming down the back of the thigh. It's got motor branches and the sensory branches. There are none in the thigh, and we were talking about this last week, and we had a couple of questions, which was really good. So the sensation for the back of the thigh comes from a different area, but the sciatic nerve does provide sensation to the leg. Yeah, so areas of the around the shin and into the foot. So, but motor branches is your hamstring group and your adductor magnus. So that is why adductor magnus is considered your fifth hamstring, because you've got biceps femoris, which is 2 heads, semimembranosus, semitendinosus, 1 head each. So that's 4. And then the vertical fibers of adductor magnus is number 5. Okay, and they all will extend the hip. So they share a nerve innervation, and they also do a similar kind of action. The difference though is biceps femoris, semimembranosus, semitendinosus, they go below the knee, whereas adductor magnus doesn't. It attaches onto the adductor tubercle, which is just part of the condyle, just above the joint. So that it will be the vertical fibers there will be a pure extension. It won't do anything to the tibia, because it just doesn't attach there. So, but the other ones will. There we go. That's why it's considered a fifth hamstring. And then the sensation on the back of the thigh, S1 to S3, we've got 3 branches: posterior thigh cutaneous, gluteal branch, which is the lower part of the buttock, so your butt crease, and then there's a perineal branch, which is basically all of the genitalia. So if there's a weird sensation to the back of the thigh, then it's likely to be coming from that kind of region there, and not the sciatic nerve, because the sciatic nerve doesn't supply skin sensation there. And then we had a look at this one as well. This was an interesting one. So we've got these were the anterior femoral cutaneous nerves. So we had the medial branch and the intermediate. Remember, we just looked at those. The obturator covered this patch here, and then the outside patch coming down to just above the knee. So all this lateral area here comes from this lateral cutaneous nerve of the thigh, which is brilliantly named because it does exactly what it says. So it's lateral, it's on the outside. Cutaneous is the skin. It's a skin sensation of the thigh. So it's a perfect one there. And then a discussion I had, I can't remember who it was with, but there's also some other nerves around here as well. So we'll look at these as we get up into the hip. And they travel along this inguinal ligament, and they drop down into the genitalia. So in females, you may lose sensation of the labia. In males, you can lose sensation or have odd sensation into the testicle. And that can be really worrying because especially with the testicle symptoms, you might think it's some kind of cancer. And quite often chaps are a bit reticent to talk about that kind of thing and get it looked at, but because they're worried about it. But it's definitely something to consider if they've got some odd sensations around this area here, just asking the question, because there are specific nerves that travel really close to the lateral cutaneous. And again, it's that thing where there's nothing wrong with your back. It may be compressed on its pathway down to the testicle and the scrotum. So if there's some kind of compression around that area, then it will make them feel numb, basically. Okay, so but there may be nothing wrong with the genitalia itself. It's coming from a little bit higher up. So again, it's not black and white. If anybody had those symptoms, I would certainly send them away to get checked out and have a scan for testicular cancer because of the symptoms. But when that's ruled out, then we're left with cutaneous nerves, okay, and some other things as well. But we'll talk about that when we get there. So again, it's not as simple as we think. So that was a bit of a recap from last week. Hopefully that was useful. And then we're on to the blood supply. So last bit of the knee, and then we'll move on to the hip next week. So your arteries around the knee, we've got where they come from is the femoral artery, and we've kind of talked about that a little bit already. Then remember I talked about this profound artery, so the deep one, the deep femoral artery, the profunda. And then we've got genicular, and remember I said that anything with genu, genum, and in this case genicular, is to do with the knee. So anything that's got those names in is to do with the knee joint. So the genicular arteries supply the knee. Okay, and we'll have a look at those. There are some other little arteries as well. And then behind the knee, where as the femoral artery changes course, it becomes what's called the popliteal artery, which should be on my list there. I'll have to add that in. But the popliteal artery is the one directly behind the knee, and it's exactly the same artery as the femoral, but it changes name when it gets to behind the knee. So we'll have a look at that as well. So just a little bit of a recap about where the name comes from as well. So artery means a windpipe. And that's what in the olden days, before we knew what arteries do, that's what anatomists thought arteries were. They thought they were windpipes because after death the arteries are empty. Because obviously there's no pumping of blood. All the blood goes into the veins or stays in the veins. So the veins are full of blood and the arteries are empty. So they thought that they were air tubes. Okay, so obviously we don't think that these days, and we realise the important job they do. But they're very thick, muscular walls compared to the veins. And this is where the knee vessels start. Okay, and they start in this femoral triangle. And we've not really covered this yet, so we will go over it again as we get up into the hip and the pelvis area. But this area up here, this is your ASIS. So this is anterior superior iliac spine. So it's the top part of your pelvis bone. And around here, that bit there, that's your pubic bone at the front. And there is a ligament that attaches from that ASIS all the way down to the pubis. And that can be pronounced a couple of different ways. So we got inguinal or inguinal. Either is good, and I'll use them interchangeably. So you've got the inguinal ligament along here, but there are gaps around the ligament or underneath the ligament where vessels can pass through. And again, when we get up into the abdomen area, we'll have a look at that and have a look at where these vessels pop through. There's your lateral cutaneous nerve. That's the one we were talking about just a second ago. So this is the supply of sensation to the skin over the lateral thigh. And you can see it goes underneath the inguinal ligament right around here where this muscle, if we follow it down, sartorius. Okay, and we've had a look at that one already. So the other muscle involved in this femoral triangle is this one here. This is the adductor longus. So if we have a look, we've got a border along here, and then where it meets, and then there's a border along here. So the inside part of your sartorius and the outside, well, the medial aspect of your adductor it forms the border of your femoral triangle. Okay? And the muscles underneath this region, all around here, so underneath these vessels, they all form the floor. Okay, so we've got that this area is quite exposed. There's only a piece of like connective tissue over the top of it, and this is where, if you feel for a pulse in the around the hip, the anterior hip, this is where you'll feel it, because there's not very much tissue in the way of you being able to palpate that pulse. So your femoral artery is here, your femoral vein is here as well, and your femoral nerve is there too. And I'll drop this in now, but we'll revisit it again. I don't know how well this translates across the world, but hopefully you're aware of them. There's underpants that are called Y-fronts back in the 70s. I don't know whether they're making a comeback. I've no idea. I'm not that trendy. So we've got Y-fronts at the here, and then we've got the nerve, artery, vein, and then your Y-fronts. So that spells navy. And that's the way to remember the order of those vessels. You'll never be able to forget that image now. So we've got nerve, artery, vein, and then your Y-fronts. So that's the order of those vessels from the outside to in. Okay, we've got these little branches. So have a look here. Do you remember that one? The lateral circumflex femoral artery. So this is a little branch coming off here, and that's going over towards the hip area. And then if you remember, that's where the femoral nerve split into its anterior and posterior divisions. Okay, so that's what happens around that area there. And then we've got these, we've got lymph nodes around this area here as well. Okay, so the inguinal lymph nodes are here, and they're really close to the again, if in a male, obviously the spermatic cord and the testicles. So you can have inflammation of the lymph nodes, you can have a lymphangitis, and then that creates swelling around that area, which can affect the nerves that drop into the testes. Okay, so that's quite common too. So there's lots of things that can go around this area that can give you odd sensation into the genitalia. Cool. And then we've got the the different branch of the artery, and then we have the saphenous nerve as well. So that starts up here and then drops down, and then continues down into the medial part of the leg. Yeah, so that around that femoral artery, the femoral triangle area, there's a lot of stuff going on. Okay, and it's the kind of start of everything for the rest of the leg. So it's really useful to get an understanding of this area. So talking about blood supply on this particular section, these are the main blood vessels. So you've got the femoral artery, the lateral circumflex coming around here, and then we've got this descending branch of the lateral circumflex. So off of that circumflex branch that goes towards the hip, we've got this descending branch, which will be useful for later. Okay, because things connect up later. And if we have a look, we've got those two arteries here. We've got the femoral artery, and then we've got the profundus as well, so femoral profundus. And so this is the deep one, this is the more superficial one. You can see the deep one is kind of wrapping around the femur and supplying the femur with blood. Okay, so surface of the femur. And then off of the femoral, okay, as it comes down here, you can see it continues down here, but it's faded, so it's going behind something. We'll have a look at that in a sec. And then there's your descending genicular. And remember, the genicular branches were to do with the knee joint itself. So we can see where those are heading to just there. right? So hopefully that will make that picture, because that just looks like a crazy picture. But if you start to break it down into all these little offshoots and you know where they're going, it starts to make a little bit more sense. Okay, so we've got main femoral, then your profunda, so the deep femoral, lateral circumflex, and then this descending branch of that lateral circumflex as well. So yeah, the reason why the descending branch is useful is because that will continue down and it will supply the patella. Okay, so it'll go down towards the and supply the patella network, and you'll see what we mean by a network in a second, because it's like a kind of spider's web, all the blood vessels all around the knee joint. And here it is. So as if by magic. So we've got the genicular, which is coming down here. Let me just move me out of the way. Here's the descending branch of the lateral circumflex. So that's what we were just talking about. And you can see how these then start to connect, and we get these connections across and linking up with other vessels. So if you have a problem with this part of the vessel, this one will be able to get blood towards that area. If you have a blockage, say here, then this one will be able to get blood to that area. So we have all of these little linkages and networks where the blood supply can get to an area, even if it's blocked off, because you've got lots of different supply from lots of different regions. And these supplies of different regions and the connection of all those vessels, they're called anastomoses. I'll show you a little slide in a second of a picture just to kind of get that in your head. But all of these little vessels where they attach and where they connect, it's an anastomoses. Right? And yeah, so we've got different genicular arteries joining in the picture. So there's a medial one there coming in, there's a lateral one there, there's a superior one there, inferior these ones, there's a medial superior there. So these are coming from the back, and there's branches coming off of the main, what was the femoral artery. As it's gone behind the knee, it then splits, and there are genicular arteries that then supply from the back as well as these ones from the front. So that the whole knee is just surrounded in a network of blood vessels. Then we've also got, so we've got this anterior tibial branch down here, but then look, just joining in on the action as well, there's a recurrent branch going back to join in with all the genicular ones as well. So even when it's past the knee, you've got one going back to help out with blood supply as well. Yeah, so there's loads of these little connections all around the knee. And then that is what I think that's probably one of the best pictures to describe what an anastomosis is. It's a union of parts, yeah, so, or branches all joining together. So this is a leaf where obviously all the leaf material is gone, and you're left with the little branches, the skeleton of the leaf. And that's a really nice image of what anastomosis is like this blood network, and especially around the knee, it's really quite evident. Cool. Okay, so last breakdown video for the knee. Let's have a look at this. So these are this is the blood supply for the knee, and we're going to start up around the hip area, so it kind of makes sense. So that femoral triangle that we were just looking at. So I also mentioned a couple of weeks ago about the adductor canal. So there's a canal that's formed between the adductor muscles and the vastus muscles, where it's like a groove down the front of the thigh, and the vessels just sit on that groove. So this is a little bit lower than the femoral triangle at the top. So the start of it is the inferior part of that triangle, and then the end of this canal is the adductor hiatus, and that's the gap in the adductor magnus that we looked at a couple of weeks ago. Okay, so again, if you've not seen those before, have a look back at those videos, but this should hopefully tie it all together. So you've got vastus medialis, adductor magnus, adductor longus, brevis, and then pectineus will be up in there as well. There's the adductor canal, so there's your vastus medialis, and that's the canal, and then there's the hiatus just there. So that it's on that bed that canal bed where these vessels will sit. So the femoral triangle starts up here. And we'll have a look at the adductor hiatus because it's to do with the knee. So that's the opening in the magnus, which is that bit just there. So obviously the adductors have been removed, and then that's where it goes. So it goes backwards through that hiatus. And then we've got the popliteal vessel. So we've got the patella down here. All this yellow stuff is subcutaneous fat. So when you take the skin off, immediately what you can see is all the fat cells. So the skin has obviously been removed, and then we're left with this subcutaneous fat area. So this is the long saphenous vein. Okay, so this will be a drain from the leg. Okay, so if you sorry about spelling there, but the saphenous nerve, yeah, follows exactly the same pathway. So the nerve and the vein, when it gets around the knee, they follow in the same direction. So it runs all the way down. So there's the vein, and then the vein then drains up here in the groin. So there's your pubic bone. There's your femoral artery and vein. Sartorius just here, so that's your femoral triangle. Let me just go back a sec. Just pause that at that point. So there's your artery and vein, sartorius, and then there's the femoral triangle. Yeah, so remember the borders were adductor longus, and then that looks like gracilis there as well. So adductor longus, and then your sartorius, medial border of sartorius, and there's your pubis just up there. So you can see that's why you can feel a pulse in this area here, because the vessels, the artery is really, really close to the skin. Okay, so and this is also a place in first aid. So if you ever have someone who's got a catastrophic bleed to their leg, you apply pressure here, and it will stop the blood supply to the whole leg. Yeah, so if they're bleeding out, then that's where you would apply pressure if you can. So sartorius has been taken off. There's gracilis. There's vastus medialis again. There's your reductor longus, which was the border of your femoral triangle. There's your magnus underneath that. There's the hiatus of the magnus there. Yeah, and then so it's the adductor canal, the end of the canal. That looks like one of your hamstring muscles around the back, so that's been taken off. And then here we are here. So this is the posterior view as it's coming through. So now it's changing. Just rewind that just a tad. So now the name of the vessel, so that's at the front, and then as it goes through that canal and through the hiatus and comes around the back, so now we go to a posterior view. There we go. So as it's spinning around, now these are the popliteal vessels. Okay, so it's exactly the same vessel, just given a different name when it comes out of the adductor hiatus, around that region there. So as it's coming down here, this is the canal, and then we've got the artery and vein, and then there's the sciatic nerve as well. And you can see how they all then start to bunch together. So this is behind the knee. These will be the femoral condyles around here and here. It's one of your hamstrings coming down. So here's your vessels from the femoral region that have just gone posteriorly, and it's now meeting up with the sciatic nerve, which was part of the posterior compartment. Okay, so now things are all starting to meet together, and then there's the back of the knee. So this is why if you do manual therapy stuff or needling or anything like that, we avoid the back of the knee, because just like the femoral triangle, which is really exposed and doesn't have very much tissue to protect it, same with the back of the knee. Yeah, so you can feel the pulse at the back of the knee because of the artery being so close, being so superficial. And if we just pause that there, so deepest vessel is your artery, the middle vessel is the vein, and then the top tissue, the most superficial, is the nerve. And that's the order in which they sit in. So if you were to scan the back of the knee, the first structure that you would be able to see would be the sciatic nerve, and then underneath that would be the vein, underneath that would be the artery. Okay, so you get a good idea about what depth things are and where the orientation of things if you know those that order. Okay, so that's the order of the vessels as they come through the back of the knee. So here's your biceps femoris, semimembranosus, semitendinosus, and then your gastrocnemius muscles here and here. So you can just see those popping through. So this is the popliteal fossa. It's like a triangle at the back of the knee. So it's formed by the gastrocnemius heads and then the hamstring tendons coming down, and you've got this triangle at the back of the knee. And in that triangle, that's where your popliteal vessels are. Okay, so this looks like the artery because it's got branches coming off of it. Have a look at that. All the yellow stuff again is the fat tissue, and then these are the genicular arteries that we saw on that picture. Yeah, and they will go round to the front. So there's the sural artery supplies the gastroc heads, and then these are the genicular arteries. Look, you can see them like poking through. Yeah, so that they'll be so the sural arteries will supply the. I'll just go back again. The top of the gastrocnemius. So we can see those like popping through here, supplying that muscle. But the genicular ones will wrap around and join up with the anterior vessels to form that anastomosis all around the patella. So let's have a look at that again. So here we got the gastrocnemius, semimembranosus, semitendinosus. There's the genicular, so it's Latin for knee. There's the medial genicular. And then there's your sural just coming off there, gastrocnemius heads. And then there's your inferior genicular just there. And then there's the lateral one. Okay, so you can see then they go around the front, connect up with the network on the patella, and that's how your knee gets its blood supply. There you go. Good way to finish. Right, let me just, that's the one I want. Pop that off and that one on. Good. There you go. There's the knee. I can't remember what episode that was of the knee. I think it's maybe 6 or 7. So good detailed look at the knee from the bones, bony landmarks, through to the connective tissue. We looked at some of the stuff with the joins in with the hip, with the IT band and the fascia lata. All the muscles we looked at and the tendons where they attach, and then obviously just over the last couple of weeks the nerves and the blood supply as well, which kind of wraps everything up. So next week we're on to the hip and the pelvis. So we're going to start looking at the bony anatomy first, start with those building blocks, and then we'll start to add on the connective tissue and so on and so on, like we do with every session. So I hopefully you found that useful, and if there's any questions, please feel free to drop them into the group during the week if you're watching on catch up, and I'm more than happy to answer those. Otherwise, I will see you next Monday, 10 o'clock. See you then.